Welcome to Physician Focus. I am Dr. Alice Coombs. In 2002, the Institute of Medicine issued a report called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. This landmark report pointed out that racial and ethnic minorities receive poorer quality care than white patients, even when insurance, income, age, and medical conditions are comparable. This edition of our program will discuss disparities in healthcare and how they affect minority patients. We'll look at some of the causes and consequences of disparities, the barriers to equal treatment, how far we've come since the Institute's report, and what physicians and patients can do to reduce these differences and improve care. With me for our discussion are Dr. Milagros Abreu and Dr. Ronald Dunlap. Dr. Abreu is the founder of the Latino Health Insurance Program in Framingham, Massachusetts, which educates Latinos about health care and works to increase their access to health services. She is a postdoctoral fellow in epidemiology at the Boston University School of Public Health and is the current vice chair of the Massachusetts Medical Society Committee on Diversity in Medicine. Dr. Dunlap is the 2013-2014 president of the Massachusetts Medical Society and former chair of its Committee on Diversity in Medicine. A physician with South Shore Cardiology in Weymouth, Massachusetts, Dr. Dunlap is also an alternate representative to the Commonwealth of Massachusetts Health Disparities Council and a member of the advisory board of the Massachusetts Health Policy Commission. Welcome.
Thank you.
Thank you for having us.
So, can you define disparities?
Disparities are the differences, so that a health disparity is a difference between the incidence of a disease in a given group or in a sex, so something may be more prevalent in a woman than in a man. But healthcare disparities are the differences in the care that's delivered for a given condition, so that two people from different ethnic groups might receive different care for the same disease, same severity. And so despite, as you mentioned, income and other factors being equal, there's still a difference in how minorities are treated and how they receive care and whether or not they're referred for advanced diagnostic procedures, et cetera.
So give me another word for prevalence. How would
prevalence
we better
is the
define
incidence or how often a disease occurs in a given population.
Okay.
So hypertension might be more prevalent or have a higher incidence in blacks. And certain other disorders might occur more in other ethnic groups based on different factors, diet, culture, and so forth.
So more common, if you will.
Right.
Some diseases are more common.
Right.
And are there ways in which these disparities in health care impact minorities in different ways from whites?
Yes, to give you an example about different articles that show that there is a major differences among the access to care for different population bases and other. Like, for example, Latinos have been identified to be less likely to have a primary care provider or source of care, even also African Americans. We can also report about different articles that show that when we ask patients about how they rate their health, for African Americans and Latinos compared to white, they have reported that their health is more poor or fair compared to white Americans.
Do you think there are other factors that impact access, if you will, their ability to get into the healthcare system?
Yes. We can mention that lack of knowledge, reduced communication between patients and providers, and most importantly, lack of information about how to assess different services in the country.
I think to some degree there's also differential access. So the number of providers within a given community may be affected by the income and socioeconomic status of those in the community, so that certain healthcare plans or medical providers may choose not to practice in that community because it's not as profitable or because the payment systems are so poor that it's not viable.
So in other words, you're saying that sometimes that patients have a difficult time finding someone to take care of them because the numbers of those type of healthcare providers, whether physicians or nurse practitioners, are less in those communities.
Correct.
Compared to other communities.
Right.
Yes.
Okay.
And we can also mention that the changes in demographics are taking an important part of these barriers and also these disparities.
What does that look like for Massachusetts compared to the United States?
Like in Massachusetts, we can mention that 10%, almost 10% of the population is represented by a Latin American resident. Mm-hmm. And we have towns when we can identify that Latinos, for example, represent about 60% of the population, like in Lawrence. We can even go to neighborhoods in the city of Boston where 25% of the population is representing either for an African American or for members from a Latin American country. So these changes making even more difficult for these individuals to access better care and better health of themselves.
Okay, that's really important. Now, we talked a little about health disparities, like the occurrence of diabetes or hypertension within different races. Now, let's drill down a little bit and go into health care disparities. What kind of things give me examples of how healthcare disparities impact patient outcomes for African Americans and Latinos and Asian Americans, if you will.
So in terms of healthcare disparities, for instance, minority patients, particularly blacks, are more likely to present with a disease such as hypertension, but they present later in the course. So they're more likely, in the absence of care, to have to go on to get dialysis, which is exceedingly expensive, rather than to receive $100 or $200 worth of medications throughout their life that would have prevented the complications of hypertension. So the end point of preventing stroke and heart attack and certain things like that is much worse. There's a higher incidence in those groups than in people who receive better care.
And what you pointed out is very important, because blood pressure not controlled leads to renal failure, and kidneys failing leads to permanent dialysis. So that's a really important point.
So when we're talking about the incidence of cancer or breast cancer, for example, for African Americans or Latinos, even that the incidence rate is not that high for these populations, but they are being diagnosed later on this stage of the disease. So they are most likely to be metastasized or end stage of this type of cancer.
So for the example you gave for breast cancer, what would be a better pathway for a patient in order to have a better outcome for breast cancer? Can you give an example of that?
Yes, like increasing the rates of breast cancer screening, like more mammograms available for these individuals. By being able to detect this earlier in the stage, we can definitely reduce not only the incidence rate, but also the outcomes come to these complications.
And some of that is education. So for instance, teaching women to do self-examination is a way of detecting this earlier without high technology, so that the fact that that education is lacking in certain communities essentially makes it so that these diseases are detected later, and therefore more costly and worse outcomes.
And to give you another example for the Asian Americans, in California they did a study where, based on the knowledge that people who don't speak, Asian American doesn't speak English, the incident rate for colorectal cancer, it was higher because they were less likely to be a screener.
So let's talk a little bit about this whole piece of patients actually coming to the hospital or going to their provider, and once they get into the healthcare system, okay, maybe they see a doctor, maybe they go to the hospital. What happens with disparities once they've actually made the effort to go to the healthcare system that results in disparities and worse outcomes?
There are still differences between the culture of the healthcare provider and the patient. And so sometimes not understanding the culture of the patient, to understand their diet, their habits, and the way they live their lives, and the ability to communicate, is a major issue in terms of trying to engage a patient. So the more you have in common with a patient, the more likely it is that you will engage them in their own health care. So that there's sometimes unwitting bias because of the inability to communicate, and then some of it is I think, subconscious, that essentially two people with the same disease with two different ethnic groups one is less likely to get advanced care than the other because of sometimes the bias of the provider.
Can you give an example of that in cardiology, perhaps?
Probably the strongest example, the two strongest examples are the difference between, first of all, men and women. That women are less likely to get an invasive, which is an advanced procedure to detect disease. Their symptoms are different. And sometimes they're not as regarded as the wage earners. So the men are more likely to get advanced procedures. The disease is different technically, so that you don't get the same care. For black men in particular, presenting with the same degree of vascular or heart disease, we're less likely to get the expensive workup. But I think someone who's viewed as a higher income or higher socioeconomic group, and even that being equal, you're still less likely. So there's clearly a bias, a racial bias that the providers are not clearly aware of.
And this is exactly what the Institute of Medicine has confirmed, that even when you are under the healthcare system, that your treatment, as you've indicated, you might not have a cardiac catheterization or workup for heart disease as quickly as someone who's not a minority patient.
Yes, it's like Dr. Donlan mentioned, but the quality, even when you control for income, age, is being identified that they have a poorer quality for individuals from any ethnic group, especially for African Americans or Latinos. And also, one of the issues that we have identified in the literature is that the bridge between communication between patient and their providers, that is really critical. So we need to improve that to help the patient to be more aware about these differences, so they can not only to be more active and proactive about their health, but also sometimes the providers need that collaboration as well.
So what can be done from a patient standpoint to decrease disparities once they've encountered a provider that they think they may not be getting the kind of treatment they deserve?
Sometimes, even with our universal health care bill in Massachusetts, because of the dearth of providers in an area, the choices are limited. And so sometimes a patient can't go on to another provider because the plan doesn't allow it. When you do have the flexibility, I think a lot of patients use word of mouth, but there are also community resources that can be checked. Certainly within your community, you can check with friends and family and others who've had good experiences with providers. The problem is that some of those providers may be oversubscribed and really loaded up with patients because they're so successful at crossing the divide between the community. So in each patient, you can find a common ground. And once you find that common ground, it tends to engage the patient, and then you get over the stiffness of the interview, and you suddenly, it's like talking to a friend. You can draw out things from patients once they're relaxed and they trust you.
I think also to be more proactive about their health, to look for more information, to reach out to organizations or community or CBOs organizations who can also assist them to identify other resources, because we are not only talking about disparity in health, but we're also talking about their environment. So they might have other issues related to the determinants of health, the incomes or maybe housing and these other areas. So be proactive, and like the organization that I work and preside, we definitely help try to educate them about health literacy, how they can be more self-managed.
So there's certain diseases like diabetes and hypertension that require you to adhere to medication and to really stick to whatever the provider has given you to have a really good outcome. And what can we do to improve adherence to medication and in terms of decreasing the disparities that result from not taking your medications? Are there some things that we can develop within the systems to kind of change the disparities that are related to the fact that you've been in the healthcare system, you've actually seen the doctor, and now you have these medications to take, but you may or may not take them based on some things? Are there some things we can do to change that?
We're moving more to a home-based system, so there's a lot of discussion about medical homes and health coaches, but there's actually, I think that technology will help us. There's actually people that I know that are working on systems that are basically smartphone-based that have already been proven to improve compliance in patients with AIDS, diabetes with the Joslin Clinic, and now hypertension with Mass General, using a software program on a phone that involves the health coach, the doctor, and educating the patient. So it puts the patient in charge, and the patient can see that compliance with the medicine improves their care. So the AIDS virus can be visualized, and the T cells which attack the AIDS virus can be visualized. And if you don't take your medicines, the AIDS virus grows. The patients could see that, and therefore they started to take their medicine.
I see.
And so hypertension, you can see your blood pressures, and your smartphone can download your blood pressures, and there's an algorithm on the phone telling you what to do and who to contact if your pressure's high, and you can see the feedback. And the patients were able to get 3 times the blood pressure lowering effect that's been obtained in the best national studies. So there are new ways that I think are being looked at to reach a larger number of patients, given the smaller number of providers, that may allow us to get very good outcomes, lower cost, and really put the patients in charge of their care.
Yes. Also, talking about evidence-based programs, we are learning about how these chronic disease self-management programs and these other educational programs that they activate and increase the participation from the patients. So the providers also need to know about this type of program so they can refer the patients, and also in terms of improving the communication with the patient.
Yes.
The patient is more proactive.
Yes.
You can have also better outcomes. But in participation with programs like the Latino Health Insurance Program, we provide health literacy and these other issues to educate more individuals from color so they can be more active about their health. We know that diabetes and these other chronic diseases are more prevalent among this population, so we definitely need to identify different tools so they can be more active.
And when you said evidence-based program, can you go evidence-based protocols and things like that? What does that mean in a layman's term?
Yes, that means that these are studies or projects which are being validated, that had gone to a different scrutiny so they can be offered to population with the safest, that they had been go to a different protocol that are available.
So it's actually been shown already with research that this is the way to go.
Exactly, and show already that they have benefits to the patients.
I think one other thing is that the provider has to be convinced that the patient has the ability to learn, because I think some of this is bias in terms of not thinking that people from lower socioeconomic groups or different backgrounds have the ability to understand and learn.
So that's really important, and I like that you brought that up, because one of the recent studies in the Archives of Surgery showed that when minority patients go to even more elite institution, academic centers, and they have surgery by surgeons who sometimes are the low volume surgeons, and also have the patients also have increased complication rates. So this speaks to this whole part of patient healthcare literacy or empowerment.
Yes.
What do you think about that as a mechanism for decreasing healthcare outcome disparities for patients?
I think that as we move forward, hospitals and practices are developing systems and protocols to make sure that each and every person gets the benefit of the best series of things for following that condition, so that the fact that one physician tells you 2 things and another physician tells you all 10 goes away if the system has a way of transferring that knowledge. And we're going to see more system-based care where hopefully we don't leave people out of the key instructions that determine the outcomes.
So I think you're saying that in this phase where we're developing a better system, it's okay to get a second opinion, is it not?
Correct.
Yes. And also the cultural competency trainings that are available for different practices. We know that with the changes in demographics, there is a priority for the practices to understand more about the cultures that they are serving. So normative values, like to give you an example, familism, so respeto para los Latinos, like something like that is really common. It's important for providers to understand about those differences so they can improve communication.
I think some of the disparities that we're talking about have to do with from infant mortality to end-of-life care.
Yes.
And we've talked a little bit about everything. We've talked about chronic disease management. We've talked a little bit about procedures. We talked about different ways we can influence adherence. What are other things within patient empowerment piece in terms of the educational piece can we do for reducing disparities? What can a patient do just from the standpoint of being already in the healthcare system? What can they do where they are? I mean, we've talked about some very, very sophisticated systems where you can monitor your blood glucose, you can monitor your blood pressure. What about patients that are thinking right now, they may be at home thinking, well, have I suffered from any disparities? Is there a way that they can kind of look into the system?
Well, talking about how you can be more proactive about your health, and some of the information that we already have shared today is that patients need to be able to communicate, to improve communication with their providers. The patient have also the opportunity to understand more about their health by participating more on the to be more an active role in their health. So when we're talking about patient activations, what we mean is you need to have an opportunity to discuss with your physician, with the providers about these issues that are impacting your health. So the awareness and to improve their communication.
So it's more of a shared decision making where each person is
Yes.
actually participating
Yes.
in this whole piece.
Yes.
Right. And you need to, so if you have hypertension, you really need to know what the goals are. What is the recommended blood pressure? At what point does my risk
Yes.
go up? So you need to know the goal
Yes.
so you can decide, am I achieving goal? If I'm not, is it me because I'm eating salt or doing
Yes.
non-compliant, or is it my physician not giving me the proper advice, or a combination of the two?
And it was said to one patient that my blood pressure is high, but my doctor tells me I run high. That's unacceptable, isn't it? And so I think these are important things. And you also brought up this whole notion of screening. When should you be screened for some of the things that we've talked about?
Exactly.
Breast cancer, for colon cancer.
Yes.
And they've done studies to look at disparities in actual screening.
Yes, and also when we're talking about that, many of these diseases are silent, like hypertension and even diabetes. You can get those symptoms later on. But some of these people, they have these diseases and they don't even know that they have it. So when they go to the doctor, sometimes there are additional complications. So it is important to start getting a screening earlier, to identify with your doctor what is the age appropriate for you to get a screen for this type of cancer, for diabetes, for hypertension, because these are resources available in your community.
What you said is really incredible, is that you may not have symptoms. You may be totally asymptomatic.
Yeah.
That means you have no symptoms. You feel pretty good.
Yeah.
And yet you need to have some basics. So I can't believe it. We're coming to the close of our program. You have been incredible guests. I'd like you to end with maybe one take-home message for our audience.
Be active, understand your diagnosis and the things that you can do to impact the outcomes. Look for providers that will work with you to achieve those outcomes. And if you're not achieving those outcomes, look for resources and other mechanisms to engage a new provider or a different system.
Thank you.
Yes, be active, communicate with your physician, like Dr. Douglas mentioned. But the most importantly, we are in a new phase in the U.S. that the priority not only is the patient, but also all the members from the healthcare system. So we have to understand more about the importance of working as a team with the providers, and at the same time, understanding about these issues. Be aware, participate, and understand about these issues so we can change it.
Thank you, Dr. Ronald Dunlap. Thank you, Dr. Milagros Abreu.
Thank you.
For more information about healthcare disparities, visit the website listed at the end of our show. And to view past Physician Focus programs, visit our website at physicianfocus.org. I am Dr. Alice Coombs. Thank you, doctors, and thank you for watching.
This is Dr. Howard Koh. It's been 50 years since the first U.S. Surgeon General's report on smoking and health. Since then, we've made great progress in reducing smoking among all age groups, but there is still so much more to do. Smoking kills more than 1,200 Americans every day, and every tobacco-related death is replaced by 2 new smokers under the age of 26. The younger kids start, the more heavily addicted they will become. Until we end the tobacco epidemic, more young people will become addicted, more people will die, and more families will be devastated by the preventable loss of loved ones. Let's work together to make the next generation tobacco-free. For information on how you can help, visit betobaccofree.gov.
I'm Dr. Alan Woodward.
I'm Dr. Douglas Adonis.
Massachusetts has made great strides in reducing smoking among all age groups through higher taxes on tobacco and laws that restrict smoking at workplaces, restaurants, and other public venues. But it's still a critical public health problem.
Tobacco use is the leading cause of preventable disease and premature death in the Commonwealth, causing more than 8,000 deaths each year. Another 1,000 adults and children die from secondhand smoke.
The health effects of smoking tobacco are well documented and severe. They include heart and respiratory diseases, stroke and cancer, as well as increased risks of complications in pregnancy and early childhood development.
If you smoke or use other tobacco products, the best step you can take is to stop. And free help is available from the Massachusetts Department of Public Health. Call 1-800-QUIT-NOW or visit online at makesmokinghistory.org.